Venetoclax in combination with low-intensity therapy, either low-dose RSC or hypomethylating agents, is broadly considered a new standard of care for older patients with AML who have not received prior treatment. We looked at we presented a poster at this year's EHA meeting, which was presented by Dr. Chin Chua, and this was focused on the question, is it necessary to continue venetoclax-based therapy indefinitely until the patient has disease progression? For this analysis, we examined patients that had received at least 12 cycles of therapy and compared a population that electively ceased treatment, not because of disease progression or toxicity, but because of physician and patient wishes to do so, versus another population of patients that continued therapy beyond 12 months until disease progression. So the median follow-up for the study population was very long, over 5 years, and included patients recruited from the Alfred Hospital in Melbourne, Australia, and also the MD Anderson in the United States, and also the University of Chicago. There were 14 patients in the elective cessation group, which we call the STOP group, and there were 14 patients in the continue until progression group, which we call the continuous group. What we noticed was that the progression-free survival using a landmark analysis revealed no significant difference amongst patients who either continued therapy or ceased therapy in terms of progression-free survival or overall survival. What was noticed, however, was that in the elective cessation group, the ultimate progression rate was 50% in this group. However, there were 50% of the patients that actually experienced a treatment-free remission that in many cases extended beyond 2 years. Furthermore, in the elective cessation group, the median cycles of therapy received overall was 17 compared to 30 cycles in the group that continued therapy until progression. And so we also looked at the characteristics of patients that were able to cease therapy, and in the majority of patients, over 80%, MRD remission had been achieved, and the vast majority of these patients either had an NPM1, IDH2 or SRSF2 mutation. And so in summary, this was a small pilot hypothesis-generating exercise, which demonstrated that treatment cessation is feasible for a small subgroup of patients receiving venetoclax-based therapy. A treatment-free remission of years can be achieved in such patients in about 50% of cases that don't relapse. And furthermore, there appears to be enrichment for patients with NPM1, IDH2 and SRSF2 mutation in patients able to achieve this goal of treatment-free remission. And so we feel that this pilot study provides the rationale to perhaps consider a future randomized study, which might consider, for instance, whether to continue or cease therapy in patients receiving treatment for at least 12 months in remission and with obviously good blood count recovery. So we hope that this information will be utilised for advantageous use in the future. Thank you.